As global populations continue to age, Geron technology is becoming increasingly important, with a particular focus on designing, developing, and implementing technological solutions tailored to the needs of aging populations. In his talk, Associate Professor Wee Shio Liang from the Singapore University of Social Sciences shares his insights on Geron technology, covering its journey from development to market. His research interests span critical areas such as aged and integrated care, frailty, health conditions, exercise, and nutrition science, offering the perspective of a health service researcher.
So when I got the invitation to come here to talk about Geron Tech, I was a bit surprised because I don't see myself as a Geron Tech person. So I thought long and hard. For the last 10 years, I did a number of studies having to do with technology and applied to older adults. Essentially, my understanding of Geron Tech is, first and foremost, to improve the health and quality of life of older adults and their caregivers. The technological application is to enable that. I want to share with you this diagram that is from WHO Healthy Aging Framework. As you can see, WHO promotes a lifespan approach. Aging starts from birth, right? And in order to maintain our intrinsic and functional capacity, we have to keep our health up, prevent chronic disease, reverse or slow decline in our capacity, as well as manage advanced chronic conditions. The health services would need to do that. And in terms of long-term care, we need to support capacity-enhancing behaviors as well as ensure good quality of life at the end of life. And in terms of an environment, we can promote capacity-enhancing behaviors as well as remove barriers. So in terms of the kind of work that we do, I will give these examples. The first one is monitoring and assessment, prevention, or care. A smart home project that we got involved with essentially is to promote capacity-enhancing behaviors as well as remove barriers, changing the environment that one lives in, as well as to possibly reverse the decline in certain conditions. The example I will share is cognitive decline. And smart diaper, it is basically to ensure a dignified late life, as well as training, physical training, gym tonic, as well as cognitive training, and then caregiver education and support for persons with dementia. So there are various stages of development and marketing of technology application. These are all what I've learned from the last 10 years. Framework of stages of development. First is idea generation. For that, Singapore has an agency called A*STAR. I will talk a little bit about that later. And then prototype development. Smart home, I was involved from stage 1 to 3. Stage 3 is prototype testing and then diffusion. We may start at different stages. For me, I tend to like to start at stages 3 and 4. But sometimes I also start from stages 1 and 2. And these are the lessons that I've learned. Basically, we want to go from stages 1 to 4 and as quickly as possible. So my focus actually is on the health outcomes because at the end of the day, we need to improve the quality of life and health of the older adults and the caregivers. So in terms of that, it is important to test clinical and community feasibility, effectiveness, as well as cost effectiveness. I think that has been discussed. So A*STAR is basically a technology agency, a national technology agency that leads the public research for science technology. Currently, its chief aim is the emphasis of narrowing the difference between lifespan and health span. In Singapore, we live about 84 years, but 10 years of that life is spent in ill health. So it's very important to compress that. Similar to Hong Kong, we are nearly super age. I think you are already there, but in 1 year's time, we will be there. But very quickly, in another 4 years, 2030, it will be 1 in 4. These are the A-star institutes. The one that I've highlighted are the ones that I have the fortune to work with to develop some of these. And in terms of tech entrepreneurs, some of them actually came from A-star. They are scientists or engineers from A-star. And two of these that I've had the fortune to know and to work with, SoundEye, which is basically part of a smart home, as well as Nero, which is the cognitive training app that I'm going to show you later. It is good to work with this institute, but every few years, the institute also changes direction as well as leadership. So that is one of the challenge as well. So most of my work are done at this Geriatric Education and Research Institute. It was actually set up in December 2015. But before that, in 2010, the government built a public hospital there. 5 years later, they decided to add a community hospital. Right now, the new hospital in Singapore, the acute and community hospital are built together. That's the model we have adopted. So as the post-acute patients can go to the community hospital and prepare for transition to go home. So when the government decided to set up a research institute, they said to base it in the Yishun Community Hospital that is going to be built at that time in 2015. So the decision to base the research institute there is a strategic one. So the photo basically shows the staff at the institute. Those people sitting in front rows, most of them are geriatricians. They don't spend a lot of time there. I'm the first full-time staff sitting there, but I'm not a doctor nor a geriatrician. So I had the good fortune to work with these people. The person to my left in the white shirt is actually my mentor, Professor Ng Zee Pin. He started the Singapore Longitudinal Aging Study since early 2000. So as you can see, when the government decided to build institute there, the funding was quite generous, and we set up 4 research programs: frailty, health services and policy research, clinical geriatrics and end of life, and geriatric education, all things that geriatricians are interested about. Nobody wanted to do the first one, so I got to do the first one. But there is no role of technology there, as you can see. Nobody seems to be interested in tech. But there was suggestion from somebody who has become a good friend to try tech to build a smart home. And I was foolish enough to listen and decided to help with that. So that's how I gained my experience. As you can see, we have all this equipment to work with the therapists from the community and the acute hospital. This is actually dual tasking. He's supposed to subtract 7 while he does the walking, but he can only walk and he can't do the subtraction. So we do that kind of work over there. So it was set up in 2015 and the funding was very generous. We wanted a smart home living lab, but the MOH didn't want to fund that. So we built a home, but no money to build the tech. So we need to secure tech partner to contribute resources. So I became a beggar to go and try to secure collaboration with various people. And I explore with A-Star because they have image and pervasive access lab. And we did actually talk for probably about 2 years, but in the end, no resources from them. And then I also got connected with Singapore Management University. Actually, they work with Tata Consultancy to have an ICT lab. So we had visits from TCS scientists, and they eventually decided to extend the funding to also to our smart home, and therefore we had some support from there. And so we do the project collaboratively with SMU. For those of you who's familiar with smart home, I'm actually not familiar, but I had to do up the home with the scientists from SMU. And so essentially, the home is wired with different sensors, and the connection is to health service provider. And importantly, we want to be able to track any early decline so as the health provider can actually delay or prevent that. That is very early stage work, but the interest is over there. IHIS is actually a national health agency in terms of tech. So other than A*STAR, there is IHIS. They spell out basically the direction the country has in terms of health technology. And in 2018, this was where the slides came from. They presented this as the research priority. So basically, is to collaborate with aging research and build a scalable platform and leverage on any existing research. But importantly, they want to measure cost effectiveness. We picked the peripheral group because we wanted to prevent functional decline and we wanted to extend health span. And so the emphasis then was to use daily activities monitoring to detect and predict early signs of cognitive decline in order to arrest that decline. So that is the emphasis, and it's totally in line with our funding objectives, although we have no money for the tech. So industry funding comes basically from SMU TCS lab. Basically, TCS invested 6 million, and we are an extension of that. I don't know if people know what TCS is. At that time, I do not know, but essentially they are a very big conglomerate. At that time, in 2012, their revenue is already 10 billion. And I checked to do this presentation is now closer to 14 billion. So they are very well resourced in terms of scientists, consultants, and so on. So this is how our smart home look like. Essentially, there are 5 categories of smart sensors technology. One is what we call PIR sensors to detect motions. The other one is pressure control, and then video monitoring, but with visual privacy, and body-worn sensors, as well as sound recognition. SoundEye is able to recognize sound and able to predict what is happening in the home. So importantly, these sensors are able to monitor daily activities, abnormal behaviors, cognitive impairment, falling, indoor person positioning, as well as sleep, and so on. And that would give us a sense of their functional health, their psychological health, as well as their social health. So with the support of TCS and SMU, we were able to wire up the house. And this is a diagram of potentially the kind of data we can get in terms of an activity map. And so the idea is from the activity map, you can predict certain conditions of the occupants. The idea of the smart home is actually to have patients from the community hospital come to stay in the smart home to help them rehab, to monitor their condition so that can speed their transition back home. It's good to be in the smart home because the hospital and the community hospital is nearby. And the first study eventually, after so long, we decided to do is to look at the ability of the smart home to monitor their 2 functional tasks that is very much related to IADL. The phone task, be able to search for who they want to call, write it down, as well as call the person. The second one is marketing, calculate, identify the groceries that they want to buy, and then add that up in order to plan their marketing. So in the end, this is how it looks like. We have people who are MCI, mild cognitive impairment, as well people with normal cognition to come and perform their 2 tasks, and using whatever is available in the home to monitor their performance. We're able to show that for the calculation tasks, those with normal cognition does significantly better. So this is ultimately achieving a proof of concept after about 4 years. And then COVID happened. This is what A*STAR Institute actually wanted from us. They wanted 2.3 million from us to collaborate with us, which eventually didn't happen because I don't have the budget. And I had to rely on TCS and SMU's kindness and collaboration to finish that first project. So what is the lesson that I learned? Am I punching above my weight? I think I was foolish. because I didn't know what it takes and what it involves before saying yes. The idea was actually came from a senior geriatrician with interest in cognitive impairment. In the States, they were doing this sort of thing. But I think ultimately, if I don't try, I won't learn as well. So it's a precious lessons learned, but it doesn't require a lot of resources because it's an extension of the project from SMU and TCS. And it's very resource intensive, requiring multi and transdisciplinary work. I have some few research associates and fellow who got involved, and it is really a very long runway to set up without experience. And the lack of budget and partnership obviously did not make it easy. Should we do studies that evaluate cost effectiveness? I don't know. Eventually, after COVID, I left. So another example is alternative to industry funding, like from SMU, is competitive funding from the government. And the government gives this kind of funding generously under the National Innovation Challenge. And the next example involves that. So smart diaper. Aging population, there are many people, especially living in the nursing home or community hospital. They are bedfast and they require diaper. The challenge is to ensure timely change of this soiled diaper. Especially, it is challenging for people who cannot communicate their needs, people with aphasia, dementia, and so on. And therefore, there is a set time where the diapers are changed every 4, 5, or 6 hours. If the diaper is dirty, say in the first hour after the change, then they have to lie in soiled diaper for another 4, 5 hours. And it can lead to various undesirable conditions that will lead to further complications. And literature shows that up to 60% of long-term care labor time is spent on incontinence. So this is a big problem. Can we find a cheap solution? The potential is also there for smart diaper to pick up diagnosis of early condition, for example, bacterial infection. But you need somebody to develop that diaper, that smart diaper. So the outcome is potentially very good and very valuable for this project. Fortunately, we were able to work with another A-star institute, which is the Nanobiotech Institute, which has very good scientists, and we have geriatrician, nurses, as well as health clinical researcher. Actually, that is myself. So we gotten a grant actually from A-star in the tune of 1.23 million to be able to do that together. The objective is to come up with a patented low-cost sensor technology embedded in the diaper that is able to detect when the diaper is dirty. And we need to show the outcome. What is the outcome? Reduce lying in dirty diaper, reduce time. So that is very clear to me that we have to be able to do that. And the good thing at YCH is that we can test it on the people in diapers at YCH. Just out of interest, this is a review that we have submitted. You need to detect both urine and feces, and there are different ways of detecting them. Urine can be wetness, can be humidity, can be electrochemical potential sensing. It can be RFID wetness sensing. Feces is more challenging. You can detect wetness, but feces are not always wet. The gas, temperature change, calorimetric. This is not my area, but the nanobiotech scientists are experts in this, as well as biomarker detection. So these are important signs in terms of development. The person behind this is Professor Jackie Ying. At that time, she was the executive director of this institute, IBN. That's the science behind it. So essentially, the wire strip is embedded in the diaper. It is very cheap. It won't significantly increase the price of the diaper. That's important. You have a transistor that can be attached to the diaper to signal when it is wet or when it is dirty to a station. Inform SMS, you can change the diaper immediately. So that's the idea from a layman perspective. The strip is made up of the urine part and the fecal part. One is in front and one is behind for obvious reason, right? So the idea is that And that's the method we have. Actually, you don't need a lot of patients, just 10 of them, to use the smart diaper for 5 days, for 14 hours each day. With the smart diaper and without the smart diaper. And so the sensor would transmit the signal to the receiver, and the receiver would then inform the caregiver to change the diaper. There are apparently 2 different systems in terms of wiring the whole thing up. The IoT system with fewer devices, which is more desirable, and the Zigbee system with more devices. This is pictures of Yishun Community Hospital. So this is the clinical trial results. So we need to basically show sensitivity. When it's wet, say that it's wet. We need to show specificity to show low specificity when it's wet, not to say that it is dry. So we need to show all that, as well as accuracy and as well as precision. So in terms of wetness, number 1 is the IoT system. Number 2 is the Zigbee system. But you can see for urine, we have very good results, over 95%. And therefore, this is the difference. The time lab, the standard care, require more than 3 hours in dirty diaper. But when you get the information for wetness, it takes 16 minutes on average to change the diaper. So time spent in dirty diaper reduced by 3 hours. The feces results is not so good, not so sensitive in that sense. So basically, we need further improvement on that. We also have a user satisfaction survey. The user in this case are the nurses and the carers from the community hospital. Pretty high satisfaction, moderate or very familiar, being able to say that it's useful, user-friendly and helpful in their work. So these are very good results. But obviously, the challenge, as I said, after we finish the trial, COVID-19 disrupt. What it disrupt is the team. It's not the study. So the team changes because COVID. Everybody would change to go to different places. I also left the institute, and Prof. Jackie Ying actually also left Singapore for Saudi Arabia. But we are very close, very promising. And we came out with the review paper early on, and we hope that Prof. Ying can continue the development, because this is finished testing, finished development, just need to refine it, and then we have a product that seems very viable. The other example is one which is later stage, and this is my favorite. Regular resistance training is actually strongly recommended to prevent sarcopenia in older adults. Who does resistance training here? 5%? 5%. So we all need to do resistance training because we want to increase our health span. You don't want your last 10 years not being able to get up from the floor. If you can't get up from the floor, you can't do a lot of things. It's in the CPG, Clinical Practice Guidelines, in terms of Singapore for treatment, diagnosis of sarcopenia. And this is a study we did in Yishun. We see that 1 in 3 older adults, age 60 and above, is 1 in 3. But even in the younger adults, 21 to 60, 6.9%. This is according to the Asia Work Group criteria. And when we survey older adults, what exercise do? They go for walks. Most of us also go for walks. But resistance training, what is that? So how to widely adopt resistance training and how to fund it? Available technology for scaling. So this is the example that I would...
A progressive strength training regime on a twice-weekly basis for 12 weeks. Gymtonic uses smart hydraulic equipment that are safe and equipped with interactive AI-based software panel to guide and track their training. Assessments are conducted before and after the 12-week training for the seniors to better understand the baseline results and to track their improvement at the end of the program. The assessment comprises body composition analysis, grip strength test, single leg balance test, chair stand test, and muscle strength test. Research has shown that seniors will experience 20 to 30% gain in muscle strength, Upon completion of the 12 weeks program, seniors also evidently show improvement in their balance, walking speed, and endurance.
So essentially, it's just a matter of putting together the system. The machine system initially was from Finland. Recently, they changed it to Fry machine from Germany. But some of the things are developed in-house, like this AI assessment panel. It was developed actually in Malaysia. And over time, the system becoming better, becoming stronger.
The 12-week training program is a structured program for all Gym Tonic. For fitness, there are many kinds. There's cardio, there's strength, there's balance. As we get older, what we tend to lose is muscle mass. That means you have lost some capabilities of either walking, climbing stairs, or simply just get around. That's where strength training comes in to maintain or at least give them back the ability to take care of themselves.
我真好，真袂驚，我10外歲，早起早來來 exercise 了。
Brisk walking is not a chore anymore. We definitely find the improvement there.
我係90歲，叫我咁樣做我咁樣做咯，係慢慢叫你嘅啦。
For me, the most obvious one is my beer belly. My beer belly sort of disappeared.
The whole place is like a big kampong. Exercise become a part of their lives. They can come in, together, exercise, and then chit-chat, and after that, they'll actually go for a meal after that.
There are quite a number of videos because the program has grown over time, and there's very good adoption as well as scaling. Because there is donor funding. It's funded by a foundation. The foundation basically fund any center who want to adopt this system. So what capital cost is funded. You just need to have the space, and we have a lot of active aging center that does that. Also rehab centers as well as nursing home. So the center would just need to meet the operational costs. And dedicated seniors gym, like I said just now, in active aging center, community center. And as you can see, as the program gets embedded in the center, it also grow in a social way as well as in conjunction with other center activities. The thing is, a lot of seniors in their 50s, 60s, when you say resistant training, they would take a step back. What does that mean? But this is very friendly. I think there are better things you can do than that lah. So I was initially skeptical as well, because that is like so clinical. But the take-up is actually very good. And over time, people are charging market rates. And there is a queue. And at any one time, there are more than 2,000 seniors in any time. So non-subsidized members pay $15 to $25 per session. That's the amount I pay for my gym session where everybody exercise together. So it is market rate. And centers are also widening the offerings to functional training, which is what I think they should do. Functional training are based on daily activities that the seniors has to do, because after 12 weeks, you don't continue to do the same thing again. You need to progress. But it's a very promising system, one which I say has basically diffused. So Gym Tonic was actually recognized. It's in the ministry report, Strategy for Fighting Frailty, but they don't give a cent because the community is able to sustain that on their own. This is actually started by an orthopedic doctor. In terms of recovery from knee surgery, they do detailed measurements. So this sensor is able to do that in the orthopedic clinic. The company basically charged the orthopedic clinic per report, very detailed report. They asked me, say, can we extend this to senior center? I say the measurements are time up and go, SPPB is very easy. How much do you want to charge them? They say $30, which is a fraction of what they charge the orthopedic clinic. I say $30, you can forget it. So they are still waiting. So it's very important. You have a product that is useful, but if the price is not correct, people are not going to adopt it, not going to use it. That's the cost part that is very important. It is able to measure accurately what is measured. So the Gymtonic model seems to be, I shared with them to say that we already have this model. Yours is not likely going to be having a market. Orthopedic clinic can pay for it, but not the active aging center. The next one I want to share is about brain-computer interface cognitive training. This doesn't seem to be something new. Different speakers may have kind of shared this, but this is developed by A-star scientists. It's called Neuro. There's already a brand. So when there was a grant call for identifying and preventing dementia in community-dwelling people who are at risk, those with cognitive frailty, basically, we got the grant and is able to implement this finger-like intervention with dual task training, with brain-computer interface cognitive training, as well as dietary guidance. So what I did, because I have to exit after I do the study, is to find providers that are already doing that and work with them using this fund to show efficacy, effectiveness of their intervention. That's what I did. So I worked with Neuro. Actually, it is the Ministry of Health that linked some of us up. And on the side, I also did a community brain training study with them. This was done in the community centers. They have an app and EEG machine, which they sell, but in the community center, they charge by session, which doesn't cover the cost. Eventually, they hope the seniors would buy the brain training app. So this is an example. So in terms of neurocognitive test battery, there are different domains: immediate memory, visual spatial language, attention, delayed memory, and those all can be tested. These are domain-specific training. It's like what the speaker has shared earlier, and automated for older adults. This is attention training.
Fly with Mindcopter, where your attention skills are fundamental to survival. Retaining excellent attention skills is key to focused learning, task performance, interpersonal skills, and safety and awareness. By improving our attention skills, you can enhance your cognitive abilities, increase productivity, and navigate the world with greater efficiency and success. With Mindcopter, your mission requires you to fly the helicopter and make stops to save stranded survivors. You'll have to deliberately engage and disengage your attention to cause the helicopter to fly up and down.
So it has basically games for different domains. The idea is there, and it's been shown to be effective to be able to improve cognition of people with normal cognition, as well as persons with at risk of dementia. We basically use a local risk score to identify those with 20% or more risk of dementia within 5 years. So we use that risk score. But when it comes to the product, they wanted to sell it for $652.91. The seniors wouldn't bite. So used in the community, they sign up as a community activity at the community center, they do. And they bring more of their friends. But if you want to ask them to buy, that's where they don't do that. So which market to sell this to? Any guess? Attention training. So the idea, the lesson I learned is actually from Alvin. Alvin was from A-star. He is a businessman now. He founded Neuro and he has got investor. This is the diagram he shared with me. So do you want to market it as a common digital health product or something that is prescribable as a digital therapy? Doctors will prescribe it. It has to show efficacy, effectiveness in treating the condition. But if you sell it as a general health product, as a game, the proof of burden is lower. So I think entrepreneurs have to decide. So in this case, Alvin has done with me, the efficacy study is shown to be effective, but the pricing is not right. But in another market, people bite. Training for children with ADHD, because doing well in school is very important. And the psychologists prescribe this training in their clinic for children with ADHD. And it's actually the same game, but for different age group. So that works very well for Alvin. Meanwhile, the Neuro for older adults are still available. The other one I want to share with you is an app that I was involved from the idea development stage. But this is taking very, very long. But the good thing is we have 2 tranches of grants that is able to help us with the continued development. So dementia is basically a loss in cognitive function, but in terms of behavior, disorientation, behavior change, increased difficulty in coping with daily activities, that's the main challenge. And most of persons are taken care of by family caregivers who often lack the coping strategies, intervention skills, as well as limited timely advice. When the behavior occurs, they don't know what to do because they don't have advice of a clinician, health professional. So this app is meant to narrow that gap, to provide care knowledge and intervention skills. It is on demand. It has recommended care support. I'm just going to go through this very quickly. This is what the people have developed together with clinicians. I'm the research person. So self-help, service recommendations, take notes each time they consult the app, and then do a trend and history so that it can be eventually personalized. The help includes the kind of behavior to match it, and then there's also a video library of different behaviors. Can refine the kind of behavior that is demonstrated, agitation, anxiousness, aggressiveness, and then repetitive behavior, depressive symptoms, and then what can be done. So in this example, aggression, because usually it's caused by physical discomfort, environmental factors, or poor communication. So the strategy is to change the environment. Try activities like physical exercise, arts therapy, and so on, creative activity. So in terms of self-help, there's also scenario to basically help the caregiver understand and narrow down what is the issue. And then service recommendations, again, refining the match and so on. There's already an app, but it's a prototype app on my phone. And suggestion of something that can be done, whether it's respite care, whether it's daycare, and so on. It's all linked to the service provider. So we basically developed and tested a prototype. And it involves co-design with caregivers. And we end up with a usable prototype with all these modules that is supported by the first tranche. We did needs assessment, we did function tests, we need utility tests for family and caregivers and health professionals. But it is a prototype. And what we don't have is a wider use that you need to recruit and work with, say, for example, dementia organization, and we stop short of that. And so this second tranche of funding is to enable us to do that. So what is the thing that we need to do? Is to test the efficacy and cost effectiveness and to scale up. So personally, just 2 weeks ago, I actually was involved with a caregiver discussion group. And one of the caregiver actually said, I did this test with this group, but the product never come out. Then I stood up and said, I'm sorry, I'm one of those that is involved. It's still under development. I'm sorry. So people can't wait because I care for my loved ones with dementia every day. And it happens every day. So do we need the cost effectiveness study for this? Do you think we need researcher with grant? They will apply because winning a grant to be able to do study is good. But that to me seems to delay the process, the delay from scaling to market. So I don't know. I'm not the PI now, so I can sit back and think about this and try to learn something from it. But I don't know. So it's a lesson that I'm learning. So how much in terms of the evidence requirement that you need? Is this going to be prescribed by a physician? I think not. So those are the lessons that I learned. But in terms of other contextual and environmental factor, I think system enabling is very important in the area of health financing. So this is a news report just from a couple of months ago. Ministry will identify impactful tech projects that can be scaled up into national project. So that is very helpful for people who are trying to apply that, especially in the healthcare setting. We also have a national level health program that is meant to combat or prevent, delay chronic diseases preventive care plan. It was actually just started last year, and the plans is in progress to add personalized medicine, because through visiting the GPs, through wearing a wearable device, through signing up for health monitoring, through this program enables more data, and those data can be used to improve the health of the populace. In terms of application of precision medicine, there's also need to be tweaks to the national health insurance system, and the government is also doing that to allow use of genetic testing. I think in the background, some of these policies changes and financing changes are important to enable progress in the use of this technology. So this is my conclusion. It is evolving rapidly. I think we all know that, and it's important, as we all are doing, to explore these opportunities in terms of helping actually ourselves age better. I'm the customer. In the end of the day, we are the customer. So these are just my humble lessons that I learned, some of them by accidents, most of them actually being in a privileged position to be able to work with these technologies. Thank you.